Hello, and welcome to another session of the Health Cover the Client course. We will continue our discussion on reproduction in this session. This session will center on sexually transmitted infections as it relates to sexuality and reproduction. Please take some time to review the objectives for this presentation before you proceed. Sexuality affects sexual practices that can influence the development of sexually transmitted infections and consequently contribute to infertility or impaired reproduction. Sexually transmitted infections are sometimes also referred to as sexually transmitted disease. Although these are used interchangeably, STD mainly refers to the disease process associated with a sexually transmitted infection. Sexually transmitted disease are caused by infectious organisms that have been passed from one person to another through intimate contact or through sexual contact, be it oral, vaginal, or anal intercourse. You should know that while the primary mode of sexually transmitted infections is through sexual contact, some organisms can be transmitted through parenteral exposure and also through blood transfusions or even fecal matter, or from mother to fetus in the uterus, which is called intrauterine, or from mother to neonate during the perinatal period, which will be through breastfeeding. The prevalence of sexually transmitted infection is a major public health concern in the United States and worldwide. Populations at greatest risk for acquiring sexually transmitted infections and suffering from the complications are pregnant women. Women are more easily infected with sexually transmitted infections and are at a greater risk for sexually transmitted disease-related health problems than men because of the very vascular and large surface area of the mucous membrane that covers the vagina. However, men who have sex with men are also at increased risk, potentially due to the vascular nature of the anal region. Drug users may also share contaminated needles, which predisposes them to STIs. On the other hand, adolescents may engage in risky behaviors such as having multiple partners and also having multiple relationships within a short period of time, which can predispose them to STIs. So now let's look at STIs across the lifespan. Children who exhibit signs of STIs may be indicative of sexual assault by an older individual. For example, chlamydia is transmitted only through sexual contact. As such, if the nurse has a client who reports with chlamydia and this client is a child, then the nurse should suspect that there is an abuse going on and report this type of abuse in a prepubescent child who tests positive for chlamydia to the appropriate authorities. People older than 50 years may not realize their risk for STDs, or they may just feel comfortable or may not feel comfortable discussing their sexuality with healthcare providers. and so they might also be at increased risk. Providers may also lack an awareness of sexual activity of older adults. So be sure to teach older adults who are sexually active about their risk for developing STDs, especially in postmenopausal women, because postmenopausal women may be at a higher risk because many perceive that pregnancy is no longer likely and thus they do not use any form of protection or barrier protection. Changing social relationships, example divorce and widowhood in the middle years, has also a greater impact on sexuality, and this can increase the risk for exposure to sexually transmitted disease. Also, physiologic changes during menopause, such as mucosal tears and from vaginal atrophy, which means the mucous membranes drying up, may also place them at a higher risk. STIs are placed in categories based on the organism that is the causative agent, or whichever organism is causing them. So STIs are classified under bacterial, viral, fungal, and protozoa infections. Treatment of each of these STIs is dependent on the particular organism which is causing it. While some STIs can be successfully cured, others are chronic, needing symptomatic treatment to prevent worsening symptoms. So let us discuss some examples of sexually transmitted disease chosen for the purpose of this course. The first type of STI that we are going to discuss is genital herpes. Genital herpes is an acute, recurring, incurable viral disease, which means this is chronic, and once you develop it, you're going to have it for the rest of your life. According to Warren et al. In your book, herpes is the most common form of STD in the United States, with 17% of Americans currently infected with the herpes simplex virus type 2 and 57.7% infected with type 1. The incubation period of genital herpes is 2 to 20 days, with the average period being 1 week, so which is 7 days. Many people do not have symptoms during the primary outbreak, but severe symptoms with secondary outbreaks. So people who have herpes for the first time may not have any symptoms, but then when they have a secondary outbreak, because herpes is chronic and it worsens over time when there is immunosuppression, they may have more marked symptoms or more severe symptoms. So severity also reduces with subsequent recurrence. So after this second outbreak, the third, fourth, and subsequent outbreaks may have reduced severity. Some patients have no symptoms at all during recurrence or viral reactivation. However, there is viral shedding and the patient is still infectious even though they don't have any symptoms. Long-term complications of genital herpes include the risk for transmission and an increased risk for acquiring HIV infection. This is not a reportable illness, and so you don't have to report it to the local authorities. Herpes is confirmed through viral cell culture or polymerase chain reaction, which is known as the PCR. These are assays or assessments of the lesions. So symptoms of herpes may include itching, blisters on the genitalia, multiple painful lesions, fever, chills, malaise, severe dysuria, lymphadenopathy, which means the swelling in the lymph nodes, especially in the inguinal area. And then the clinical cause in women is more severe than men, for physiological reasons. So, herpes infection can also be transferred from the mother to the fetus or the child during birth. And this is known as herpes encephalitis. This can cause easy bleeding, breathing difficulties such as rapid breathing and short periods without breathing. This can lead to the flaring of the nostrils and grunting, or a bluish appearance in the child. The child may also have yellow skin and whites of the eye. The child will have weakness, low body temperature, hypothermia. This is due to an inability to control body temperature. And poor feeding. They may also have seizure, shock, or even coma. Liver, lungs, and kidneys may also be involved, so this child can have an acute liver or kidney failure. And they may also have blisters in the skin. So these are some of the assessment findings that you see in a child who has acquired herpes from the mother. Intrauterine effects on the fetus include eye disease such as inflammation of the retina or choroidal retinitis, severe brain damage, and sores or skin lesions. Implications for birth include the fact that if no active lesions are present at that particular time, then the provider may deliver the baby vaginally. But if there are lesions, or if the provider is unsure about the presence of active lesions at the time of labor, then a C-section or cesarean birth is indicated to prevent the transfer of the infection from the mother to the baby. So, if the water breaks and active lesions are present, baby must be delivered by C-section within 4 hours to prevent cross-contamination and intrauterine infection. Treatment of herpes include antiviral drugs, and the drugs decrease the severity and promote healing, and decrease the frequency of outbreaks, but they do not cure the infection. As I said, this infection is chronic, and once you develop it, you are not going to be able to cure it. So nursing considerations include administering oral analgesics as prescribed during an outbreak, and also applying local anesthetic sprays or ointment as prescribed to the lesions, which can be very painful. Ice packs or warm compresses can also be applied to the patient's lesions, and a sit bath, which is a cool sit bath, can be used 3 or 4 times a day. Urge an increase in fluid intake, or encourage the patient to increase fluid intake to replace fluid lost through open lesions, and encourage frequent urination to avoid urinary stasis, which can cause pelvic inflammation or inflammatory disease, which is an infection in the pelvis. You can also pour water over the patient's genitals while voiding, or encourage voiding while the patient is sitting in the tap water or standing in a shower, and this will reduce the pain that the patient may have. If the patient is unable to void due to the pain, catheterization may be indicated. So you as the nurse will insert a urinary catheter to make sure that there is no urinary stasis. You can also encourage genital hygiene and teach the patient or the client to keep the skin clean and dry. So by keeping the skin nice and dry, it will prevent the spread of the lesions. Then you have to also teach the client to wash hands thoroughly after contact with lesions, and you as the nurse will also have to wash your hand after any form of contact with the lesions. Make sure you are also using gloves. Ask the patient to launder any towels that have had direct contact with lesions, so they shouldn't share towel with other people's other people. They should wash their towels after they have used it to make sure that the infection is contained. So when you are applying ointment, as I said, make sure that you are wearing gloves to protect yourself, and advise the patient to avoid sexual activity when lesions are present, because it's going to be uncomfortable during the pain, and it can also help spread the infection to their partners if lesions are active. Another thing you have to note is to advise the patient to use latex or polyurethane condoms during all sexual exposure. So they should use condoms or barrier protection during any sexual contact to prevent the transmission of this illness. Instruct them to also report the side effects and risk versus benefits of antiviral agents that they are going to be prescribed. And then when they visit their healthcare provider or when they meet new partners, encourage them to discuss their diagnosis with these partners. They will also require some form of counseling, such as understanding the emotional effects of herpes, because the emotional effects can be devastating and it affects all future sexual practices and relationships, because they can possibly transfer this infection to their partners. So educate them on how to raise the topic with a partner, how to disclose the fact that they have a herpes diagnosis, and then discuss their knowledge about this with the partner. Oral meds that are used to treat herpes include acyclovir, and all these other medications are antivirals that will be given episodically or suppressively. So this means that they are given only when symptoms are present to calm down the symptoms. And we've already talked about the comfort measures that can be done. Okay. The next illness we will talk about is chlamydia. So chlamydia is caused by a bacteria known as Chlamydia brochomatis. Chlamydia cases continue to increase yearly and is reportable to the local health department in all states. So if you have a diagnosis, which is a new diagnosis, you have to report this to your local health authority, not the patient's partner or not the patient's physician, but the local health authority. Risk is highest in African American women between 15 and 24 years of age. And in women, 20% to 40% of those infected will develop pelvic inflammatory disease. And this is important because if you don't treat the chlamydia, then it is going to result in pelvic inflammation, which is an infection of the pelvis. Many females have no symptoms, and symptoms in females may include mucoid or vaginal discharge and vaginal spotting, which is bleeding between menstrual cycles, or postcoital bleeding. And sometimes this can be mistaken for irregularities with menstrual cycles. They may also have dysuria from bladder infection or painful urination. Symptoms of pelvic inflammatory disease are vague pelvic tenderness, often reported as abdominal tenderness, and in sexually active women younger than age 20, sometimes because of their sexual activity, maybe having multiple partners and all that, they don't really recognize these symptoms. That is why they are at a higher risk. So in males, symptoms may include clear mucoid discharge from the penis and frequent urination or dysuria. The CDC recommends routine screening of all young women younger than age 24. So if you have a client that is coming in for a prenatal visit, if they are younger than 24, then you are going to educate them about the testing of chlamydia and then go ahead and test them. Older women who do not use a barrier method of birth control also have to undergo routine screening. And any woman with a new sex partner or who has multiple partners have to also be screened for chlamydia. And every pregnant woman at the first prenatal visit, as I mentioned, should be screened for chlamydia. Diagnosis includes cervical culture, both in the males and female. So males do not have cervix, but you do a semen analysis and culture in the males to be able to diagnose your chlamydia. Treatment of chlamydia include the use of azithromycin or Zithromax, 1 gram orally in a single dose, or doxycycline or monodox or doxycaps, 100 milligrams orally twice a day for 7 days. However, the Zithromax is preferred because you only have to give 1 dose and they can take it right there and you know that they have been treated. The partner must also be treated even if they don't have any symptoms, because it's considered that once the other partner has it, then the partner is also going to be automatically infected, and so you treat them as well. The next STI that we will talk about is gonorrhea. Gonorrhea is a sexually transmitted bacterial infection, which is the oldest known STI. So it's been around for a very long time. It can be infected, or a person can be infected either by genital to genital contact, but can also be spread by oral to genital and anal to genital contact. The incidence of drug-resistant cases of gonorrhea is increasing because of the rate of infection among people. About 300,000 infections of gonorrhea are reported every year, so you can see how frequent or how high the incidence rate is for gonorrhea. The infection can be asymptomatic in both men and women, but women have more of asymptomatic symptoms or silent symptoms. Infections are more often silent, or women most often do not have any signs and symptoms as compared to men. If symptoms are present, men usually notice dysuria, which is painful, urination, and penile discharge that can be either profuse, yellowish green fluid, or scant, clear fluid. The urethra is most commonly affected, but infection can extend to the prostate, the seminal vesicles, and the epididymis as well. Men seek curative treatment sooner, usually because they have symptoms and thereby avoid some of the serious complications. On the other hand, women may report a change in vaginal discharge, which may be yellow-green, profuse, odorous, which means foul-smelling, urinary frequency, or painful urination. The cervix and urethra are the most common sites of infection, and anal manifestations may include itching and irritation, rectal bleeding or diarrhea, and painful defecation during the passage of bowel movement. So assess the mouth for reddened throat, ulcerated lips, tender gingiva, and lesions in the throat, all of which will be indicative of gonorrhea infection. All patients with gonorrhea should be tested for syphilis, chlamydia, hepatitis B, and hepatitis C, as well as HIV infection, if possible. Examine for herpes simplex virus also, and HPV, because they may have been exposed to these STDs as well. Gonorrhea is highly communicable and can be transmitted easily from one person to another person. So sexual partners who have been exposed in the past 30 days should be examined, and specimens should be obtained, cultured, and then they should receive treatment for gonorrhea. Advise the patient to return for a follow-up examination if symptoms persist after treatment, because most treatment failures are as a result of reinfection from untreated partners. That's why it's very important that all partners within the last 30 days will be tested and treated. So treatment medications include ceftriaxone, and this is given IM times 1 time, and this is very, very effective, and also it allows for compliance because you only have to give it 1 time. The CDC also recommends concomitant treatment of chlamydia. So if you treat somebody for gonorrhea, then you are also supposed to give the antibiotic for chlamydia together, because it is believed that if someone is exposed to gonorrhea, they have an increased risk of contracting chlamydia as well. Both gonorrhea and chlamydia are, if both gonorrhea and chlamydia are positive, then they must also be treated for syphilis. So when somebody comes in with chlamydia, you're going to treat them for chlamydia. But if they have both gonorrhea and chlamydia, then you're going to treat them as well for syphilis. Syphilis is usually transmitted by sexual contact and blood exposure, but transmission can also occur through close body contact, such as kissing. It develops at the site of entry, which is called inoculation of the organism, 10 to 90 days. So the incubation period is 10 to 90 days after exposure. 3 weeks is the average, which is 21 days. So changes may be found on any area of the skin or mucous membranes, but occur most often on the genitals and also the lips, nipples, and hands, and in the mouth, anus, and rectum. The canker begins as a small pupil. Within 3 to 7 days, it breaks down into its typical appearance, which is a painless indurated or raised smooth weeping lesion. Secondary syphilis develops 6 weeks to 6 months after the onset of primary syphilis. During this stage, syphilis becomes systemic, and it is a systemic disease and is commonly mistaken for influenza because the symptoms or the manifestations, which include flu-like symptoms, are very similar to influenza. So the symptoms of systemic syphilis are malaise, which is tiredness, low-grade fever, headache, muscular aches, sore throat, and also some moderate weakness. The patient may also have a generalized rash on the skin. There is no typical appearance of this rash except for its presence on the palms and soles of the feet and on mucous membranes. So secondary syphilis can lead to multi-organ failure if it is not controlled or treated. And so excuse me, you may see a patient that is going into multiple organ failure as a result of systemic syphilis. Screen all pregnant women at the first prenatal visit and in the third trimester for lesions because syphilis can be transmitted from the mother to the baby or to the child. Assess the client with gloves because lesions are highly contagious and you don't want to be infected with this. In treating syphilis, normally a penicillin is given that is called benzathine penicillin G, and this is given as a single IM dose. There are some reactions that patients can have in response to this medication, and so you have to educate the client to report any signs and symptoms of allergic reaction. This is known as JH reaction, and this is an acute febrile reaction often accompanied by a headache, myalgias, which is muscle pain, and arthralgias that develop within the first 24 hours of treatment. The reaction may be treated symptomatically with analgesics and antipyretics to reduce the fever and the pain which is associated with it. If treatment precipitates this reaction in the second half of pregnancy, women will be at an increased risk for preterm labor and birth. So you have to prepare for the potential of a preterm delivery. They should be advised to contact their healthcare provider if they notice any change in fetal movement, such as if there is no fetal movement within 12 hours, then they should be concerned about that and report it. If they have any contractions which are consistent and which also increase in intensity or shortens within a time frame. So keep clients for 30 minutes after injection to assess for this allergic reaction, and clients should follow up for blood tests and evaluations at 6, 12, and 24 months after treatment of syphilis to make sure that the bacteria has been eradicated from the blood. All sexual partners must also be prophylactically treated as soon as possible, and preferably within 90 days of the diagnosis. So, in taking care of patients that have developed STIs, or in counseling patients on STIs, we have to engage in health promotion. And this includes your primary prevention, which is patient education, to teach them that abstinence is actually the best because it avoids all forms of sexual contact. And then to use a barrier method, such as condoms, to help prevent coming in contact with bodily fluids. And then you also have to educate your patient about safe sex practices, such as being in a monogamous relationship, knowing the STI status of your partner before sexual intercourse, and also avoiding multiple partners and engaging in risky unprotected sex. They can also get the HPV vaccine, which will protect them from contracting HPV, and also they can get a Hep B vaccine, which you all got before coming into nursing school, to help protect them from hepatitis B. Then encourage your patients as a form of primary prevention to limit alcohol use, because alcohol can impair judgment and make you take more risk when it comes to sexual activity. And also drug use, because the sharing of needles can aid or increase the transmission of certain types of STIs. So these assessment skills you have already seen on the previous presentation, and I just want you to once again look at it and see how these assessments are performed. Clinical management of STIs includes screening for cervical cytologic screenings, such as your pap smear, which you do every year, HIV screening, screening for other STIs, such as those that we have talked about, because early detection and early treatment can save an individual from all the complications that may result from having contracted an STI. And then we come to the collaborative aspect of caring for a client with STI. Note that some of these conditions are reportable, such as your chlamydia, gonorrhea, syphilis. You have to report to your local health agency, and this can be your local health department, or in some cases the CDC. You also have to work with the patients on referrals. So if they receive treatment, you're supposed to refer them to counseling, and also to reproductive health classes, to health coaches, to help them avoid transmission and reinfection. Then connect your patient to community resources, such as support groups, such as safe needle exchanges for drug users to go and exchange their dirty needles for new ones. So chlamydia infection, gonorrhea, syphilis, human immune deficiency virus or HIV infection, and acquired immune deficiency syndrome are reportable to healthcare authorities in every state. And so make sure that you are reporting these when you have a patient with these conditions. So this brings us to the end of our STI presentation. Note that we didn't cover all the sexually transmitted infections there is, because for the purpose of this class we have some examples that we focus on, and then you can use this knowledge to learn more about the other infections, and also how to care for patients who have such conditions as sexually transmitted infections or sexually transmitted disease. So thank you for listening, and make sure you do the readings before you come to class.